Our topic for this presentation is cardiac chest pain, secondary to acute coronary syndrome. On this slide, you can see our concept map. Here, we explore the relationships between the pathophysiology of the disease, risk factors, signs, symptoms, diagnostic tests, complications, medications, and management. We will expand on these topics as the presentation continues. Acute coronary syndrome occurs due to reduced blood flow to the heart. This reduced blood flow stops oxygen from reaching the cells of the heart, leading to myocardial ischemia. Without oxygen, the heart muscles would begin to starve, become injured, and even die. This is the reason people feel pain during angina and heart attacks. Myocardial ischemia is a result of complete or partial blockage of the coronary arteries. This blockage can be caused by a clot, plaque, or vasospasm in the coronary arteries, also known as coronary artery disease. Coronary artery disease can develop into acute coronary syndrome. Coronary artery disease is the narrowing or blockage of the coronary arteries, usually caused by atherosclerosis. Atherosclerosis is the buildup of cholesterol and fatty deposits, called plaques, on the inner walls of arteries. The plaque formation or process of atherosclerosis can be seen in this diagram. First, there is an injury to the endothelium of the blood vessel wall. Lipids, cholesterol, calcium, and white blood cells accumulate within this lesion. This is known as a fatty streak. The plaque is completed when collagen covers the fatty streak like a cap. This is called a fibrous plaque. The vessel then becomes narrowed and blood flow is reduced. When a fibrous plaque ruptures, it becomes a blood clot or a thrombus. This is known as a complicated lesion. When a blood clot is formed, it can lead to further narrowing or total occlusion of the blood vessel. The clot can also break off and become an embolus. It can travel to the heart, lungs, brain, or anywhere in the body and block the flow of blood. When ischemia is prolonged and not immediately reversed, acute coronary syndrome develops. There are two main types of acute coronary syndrome. They are myocardial infarction and unstable angina. Myocardial infarction is commonly known as a heart attack. Myocardial infarction occurs when the supply of oxygen to the heart muscle cells is too low and they begin to die, resulting in permanent damage to muscle tissues. There are two types of myocardial infarction, STEMI and non-STEMI. STEMI, also known as ST segment elevation myocardial infarction, is the most serious type of heart attack. During a STEMI, there is a long interruption to the blood supply. This is caused by a total blockage of the coronary artery, which can cause extensive permanent damage to a large area of the heart. A STEMI is diagnosed by an ST elevation seen in an ECG. A non-STEMI can be less serious than a STEMI because the supply of blood to the heart may be only partially rather than completely blocked. A non-STEMI is a non-ST segment elevation in an ECG. As a result of the partial blockage, a smaller section of the heart may be damaged. However, a non-STEMI is still regarded as a serious medical emergency, and without treatment, it can progress to serious heart damage or STEMI. Unstable angina occurs due to the narrowing of the coronary arteries by partial blockage of a plaque or blood clot that is reducing the supply of blood and oxygen to the heart. When acute coronary syndrome doesn't result in cell death, it is called unstable angina. Even when there is no cell death, the decrease in oxygen still results in heart muscles that don't work the way they should. Later, it may lead to a heart attack. In unstable angina, the blood supply to the heart is still seriously restricted, but there is no permanent damage, and so the heart's muscle is preserved. Risk factors for acute coronary syndrome are attributes, characteristics, or exposures that increase the likelihood of a person developing the disease. Modifiable risk factors are those risk factors that can be modified as they are influenced by lifestyle and treatment. Some modifiable risk factors for acute coronary syndrome include smoking. Smoking is considered one of the major causes for myocardial infarction as it is strongly correlated with premature atherosclerosis and cardiac death. Nicotine in cigarettes boosts the release of epinephrine and norepinephrine, which increases peripheral vasoconstriction. Hence, the blood pressure and heart rate increase and lead to dysarrhythmia. Nicotine also stimulates platelets to clot in coronary arteries. Alcohol. Frequent and large consumption of alcohol increases atherosclerosis progression. It causes an irregular heartbeat due to the damage of heart muscle. Hypertension. Chances of developing heart disease is higher in people with hypertension. Over time, hypertension increases the work pressure of the heart by enlarging and weakening the left ventricle. As the hypertension worsens, possibilities of serious cardiovascular incident increases. Diabetes mellitus. Acute coronary syndrome is more likely to occur in a person with diabetes. 65% of the people with diabetes die from cardiovascular disease and stroke. People with type 2 diabetes are prone to have high blood pressure, lipid problems, and obesity, contributing to cardiovascular event. Elevated serum cholesterol and lipid levels. Blood cholesterol increases chances of coronary artery diseases. Accumulation of cholesterol in coronary arteries promotes damage and blockage of arteries by fatty deposits and plaques. Obesity. Obesity is directly related to myocardial infarction. Abnormalities in lipid metabolism, resistance of insulin, endothelium dysfunction, and adipokines imbalance in people who are obese increases the risk of developing atherosclerosis. Reduced physical activity. Inactivity gradually increases blood pressure and body weight, increasing the chances of myocardial infarction. Other possible modifiable risk factors include poor nutrition, a stressed psychological state, elevated homocysteine serum levels, illicit substance use, and low socioeconomic status. Non-modifiable factors are biological and genetical factors which cannot be manipulated. Non-modifiable factors for acute coronary syndrome include increasing age. Around 80% of acute coronary syndrome occurs in people aged over 65. Gender. Men are more likely to get acute coronary syndrome compared to women. However, the rate of this increases in women after menopause. Hereditary and family history. Acute coronary syndrome is likely to occur in a person with family history of the disease. Ethnicity. There is a higher incidence in Indigenous Australians. Diseases that are associated with acute coronary syndrome and chest pain include a history of coronary artery disease, diabetes mellitus, and metabolic syndrome. Chest pain or discomfort are often the first symptoms associated with acute coronary syndrome. Patients express feelings of tightness and pressure around the chest, shoulders, back, and jaw. There are variations in the signs and symptoms depending on the type, pathology, and severity. This slide details the signs and symptoms of the two types of acute coronary syndrome: myocardial infarction and unstable angina. Firstly, myocardial infarction, or also commonly known as heart attack, may not have the same effects on all people. The experience varies from one person to another depending on the severity of their heart condition, age, gender, and so on. However, the most common symptoms are increased pain on the upper zone of the body, such as chest, back, shoulder, or jaw. The pain can be persistent, which means that it may continue for a prolonged period. The pain can also be intermittent, which means that the pain can suddenly increase or flare up within minutes. This pain is not relieved by rest and requires medical help. Other symptoms of myocardial infarction include high heart rate or tachycardia, shortness of breath, excessive sweating, coughing, nausea, vomiting, development of fever, lightheadedness, or dizziness. Females are more likely to show other flu-like symptoms, such as clamminess or cold sweats. The other type of acute coronary syndrome is unstable angina. Unstable angina also brings chest pain and discomfort that feels like squeezing, crushing, burning, or aching, even when at rest. Stable angina is triggered by physical activities or extreme stress. However, unstable angina is sudden and worsens quickly over a short period of time. Its signs and symptoms are feelings of severe and sudden discomfort in the chest area, even while at rest. The pain may last from 15 to 20 minutes and will worsen over time. Other symptoms of unstable angina include hypotension or low blood pressure and shortness of breath. Pain from unstable angina does not respond well to pain relievers like nitroglycerin. Hence, the person should seek professional and medical help immediately. Diagnostic testing. Electrocardiogram, or ECG, and serum cardiac markers are required to make a primary diagnosis of acute coronary syndrome to determine whether the condition can be classified as myocardial infarction or unstable angina. An ECG measures electrical activity of the heart and should be performed within 10 minutes of presentation. It is important to distinguish between ST elevation MI, STEMI, and non-ST elevation MI, non-STEMI, or unstable angina for diagnostic purposes. Patients with STEMI tend to have a more extensive myocardial infarction associated with a complete coronary occlusion. Unstable angina or non-STEMI patients usually have transient thrombosis or partial coronary occlusion. Serum cardiac markers are released into the blood in cell death as a result of infarction to the heart tissue. Troponin is a highly specific indicator, and a positive result indicates myocardial infarction has occurred. Creatine kinase MB is also specific to myocardial cells and helps measure myocardial damage. Non-STEMI have elevated cardiac troponin levels, whereas unstable angina produces symptoms similar to MI without elevated cardiac troponin levels. Other tests can be done to rule out other causes of symptoms or to personalize diagnosis and treatment specifically related to non-STEMI and unstable angina, which include a coronary angiogram uses CT imaging to see the heart's blood vessels. A catheter is inserted through an artery, usually in the arm or groin, to the arteries in the heart, and a dye flows through the catheter into the arteries, revealing any blockages or narrowing. Echocardiogram records sound waves and produces a live image of the heart to determine direction and flow of blood through the heart and measures valve abnormalities and cardiac function. Chest X-ray is done to examine the heart size and contour. Nuclear cardiology involves radioactive isotopes being injected into the blood that are absorbed by the heart muscle. A specialized camera supplies information on myocardial contractility, perfusion, and acute cell injury. Computerized tomography, or CT, uses specialized cardiac CT technology that produces multiple images, cross-sectional 2D slices of the heart to detect coronary circulation and blood vessels. A stress test evaluates the effect of exercise on cardiovascular function, while vital signs and ECGs are monitored. Complications of acute coronary syndrome. Arrhythmias are the most common complication after a myocardial infarction, where the intrinsic rhythm of the heart is disrupted, causing tachycardia, bradycardia, or an irregular heart rate. Ventricular arrhythmias are a common cause of sudden cardiac death and must be treated immediately. Heart failure may occur due to pump failure and the heart being unable to pump sufficiently to maintain blood flow to meet the body's need. Cardiogenic shock occurs when oxygen and nutrients supplied to the tissues are inadequate because of severe left ventricular failure. This occurs less often with early treatment of myocardial infarction, but when it does occur, it has a high mortality rate. Papillary muscle rupture may occur if the infarcted area includes or is near the papillary muscle that attaches to the mitral valve. This is rare but life-threatening as it causes mitral valve regurgitation, which aggravates an already damaged left ventricle by reducing cardiac output even further, and the patient undergoes rapid deterioration. Ventricular aneurysm results when the infarcted myocardial wall is thin and bulges during a contraction. The patient may experience heart failure, arrhythmias, and ventricular rupture, which is fatal. Ventricular aneurysms comprise thrombi that can lead to an embolic stroke. Pericarditis, a common complication, is inflammation of the pericardium and may result in decreased ventricular function, cardiac tamponade, and heart failure. Procedural complications such as access site bleeding, retroperitoneal bleeding, stroke or pericardial effusion, bleeding due to antiplatelet therapy and anemia, renal insufficiency, hypotension, and adverse effects due to excessive medications. Elderly patients have a high risk of rehospitalization and death from cardiovascular causes. Clinical management of the patient by the healthcare team in the hospital setting. When a patient presents to ED with chest pain, the healthcare team needs to perform assessments to determine what is happening and also provide the patient with medications and treatment that reduce their symptoms and risk of permanent damage. When a patient is diagnosed with acute coronary syndrome, the nurse should monitor the patient's symptoms and be aware of treatment options available to relieve and improve the condition. Typical examples are vital signs monitoring, pain management and assessment, hemodynamic monitoring, fluid balance review, and cardiac monitoring via ECG. Vital sign monitoring is the most important and fundamental way to check a patient's signs, symptoms, and monitor for deterioration. Pain management and assessment is done using the Socrates mnemonic tool. S is site, O for onset, C for characteristics, R is radiation, A for associated symptoms, T for timing, E for exacerbating or relieving factors, and S for severity. Hemodynamic monitoring and ECG are the primary care for acute coronary syndrome patients. Hemodynamic monitoring assesses how well the blood flows through the blood vessels. This can help identify signs of complications such as heart attack or pulmonary edema. In addition, fluid balance monitoring is essential for cardiac patients. If the fluid status is reviewed, the patient may indicate or develop heart failure, and thus relevant information can be provided. Finally, an ECG is not required for all acute coronary syndrome patients. It should be done when first diagnosed, but during management it is not always necessary unless the patient is at high risk. Continuous ECG is sometimes performed if the patient is at an intermediate risk and cardiac monitoring is not required at low risk. Healthcare workers should anticipate the potential need for basic life support. Primary percutaneous coronary intervention, or PCI, refers to the strategy of taking a patient who presents with STEMI, directly to the cardiac catheterization laboratory to undergo mechanical revascularization using balloon angioplasty, coronary stents, aspiration thrombectomy, and other measures. PCI is the first line of defense in a myocardial infarction that has been confirmed by cardiac markers and ST elevation on ECG. Coronary surgical revascularization involves coronary artery bypass graft surgery. Coronary artery bypass surgery is appropriate when PCI or medications are contraindicated. During coronary artery bypass surgery, a healthy artery or vein from the body is connected or grafted to the blocked coronary artery. This grafted artery bypasses the blocked portion of the coronary artery. This creates a new passage, and oxygen-rich blood is routed around the blockage of the heart towards the heart muscle. Medication. Medications for acute coronary syndrome include pain relief, antiplatelet agents, anticoagulation agents, glycoproteins, and antihypertensives. Patients with chest pain are given nitroglycerin, also known as GTN, for pain relief. GTN is a vasodilator, hence it will allow vessels to expand and let more blood into the heart, in turn reducing angina. GTN should not be given to patients presenting with high blood pressure, as it can worsen these symptoms. GTN is given sublingually as a tablet or spray, IV or transdermal. It usually relieves pain in 3 minutes and lasts for 30 to 60 minutes. Morphine is also given to reduce pain and relax the heart. By relaxing the heart, the demand for oxygen reduces. Platelets play an essential role in the formation of thrombus. To reduce clots, antiplatelet drugs are introduced. Aspirin and clopidogrel are typical antiplatelet agents. Sometimes they are used together, and this is known as dual platelet therapy. Many patients undergo dual platelet therapy for 12 months after myocardial infarction, regardless of how they were managed. Anticoagulants such as heparin and warfarin are used to prevent clot formation. However, not all acute coronary syndrome patients have been prescribed anticoagulants due to the risk of bleeding. Hypertension is a major cardiac risk for acute coronary syndrome, and antihypertensive drugs such as beta blockers and ACE inhibitors have been associated with improved outcomes. Beta blockers should be started early if there are no signs of hypotension, heart failure, bradycardia, and so on. Besides, ACE inhibitors are generally recommended to be started within 24 hours, and calling on the first day of onset can reduce the incidence of cardiovascular events and reduce the risk of heart failure. Thrombolytic agents such as atelipase, retiplase, tenecteplase are used to break down existing clots. These drugs can be administered IV to dissolve the thrombus in the coronary artery in order to restore perfusion.